most people in these surveys. And I'll post the link in the chat as well.
Great, thank you very much, Govind, for that illuminating talk. I think that you've raised so many issues which are absolutely vital. These are all incredibly, first of all, challenging things to discuss, but very important in the context of this pandemic. And the recommendations, the 6 recommendations that you all proposed, and thank you very much if you could put a link to your article as well on the chat board. And for those of you who are participating, feel free to please put your questions, comments, and reflections on the chat board. We'll come back to them as we think about responding to particularly, I'm going to be very interested in talking a little bit more about the notion of instrumental value and the notion of reciprocity, especially when we think about a global viewpoint as opposed to a US-centric viewpoint. Now I'm very happy to invite our second speaker, Sarah Vitone. Sarah is an assistant professor at Georgetown University and a bioethicist at the Pellegrino Center for Clinical Bioethics. Sarah's been doing clinical ethics stuff for a long time, and as well as research ethics. She's actually already been involved and engaged in COVID-19 and ethical responses in terms of looking at institutional responses as well as looking at issues around clinical trials. So Sarah, if you can go ahead and make your opening comments, over to you, please.
Sure. So Michelle, my video won't start. I think I've clicked it and it says, okay, let's try again. And there I am. Hi, welcome to this wonderful session that I've been invited to, and I'm really pleased to be here. And Dr. Prasad has set us up for a nice conversation, and I just have a couple of nuances to potentially add, but I'm going to go on to my next slide. As has been indicated, Michelle? Thanks. Has been indicated, right? We've been planning for when you think about disaster management and various things that we've been doing in healthcare, pandemic has been on the plate. But how we do resource allocation is different because we have a much more prolonged impact. There's a longer peak. Resources sometimes have to be moved around. There's lots of mitigation that we do. And we have a potential degradation in our infrastructure. And that's something that really is heavy on our minds. Next slide, please. And Dr. Prasad has mentioned a little bit about how we are trying to maintain out of our crisis mode. We're in this contingency area, and so with all of our supplies and our staff and the various pieces that we're going to try to avoid crisis as much as possible. Next slide. Our fundamental premise here is that ethics will continue to guide us, so we need it more, not less. We need to let it help us in providing our necessary framework in new circumstances that we have. So next slide. Our usual ethics, right, is around beneficence. We want to benefit persons and also to do things that don't benefit our patients. We have to think about respect for persons, how we can support our patients to be continuing as much as possible to be moral agents themselves. Next slide. And in extreme circumstances, we have to also embrace the idea of solidarity and participation. So the things that we respect amongst ourselves, the common good, the mutual things that bind us, right? It's not just the sum of the individual goods, but it can be an integral sense in that way of the common good. Thinking about participation, how are stakeholders being involved in developing and implementing criteria? Are all the voices at the table as we start to move forward? We have to think about justice and stewardship, use of resources, to be attentive to maximizing effects and minimizing risks. We have a duty to plan, to safeguard, to guide. And all of this, we have to think about equity, being treated equally, providing the same quality of care to persons when they need it, to the degree that they need. These are all important thoughts that we have, and I will add in my 2 cents on reciprocity here also. I think that we need to think about when organizations are asking employees to step into the fire, how do we then respond to that, to protect them, to keep them well? And those kinds of reciprocal relationships are very, very important. So next slide, please. I just will mention in public health ethics, we sometimes see that idea around utilitarianism. We definitely want to save the most, but I do think it's kind of an idea to think about how we can relate to one another and how we can try to not have as much conflict so that the interests of the few is not necessarily better or worse than the greater good. So I think that we have to think about that all together. Next slide, please. So as has been mentioned, public trust is the key. The public will bear the consequences of the allocation decisions that we are making. So it's important, as we've seen in the studies that have been done, that the public's values are central in how we are making these decisions. Successful allocation, again, will require their cooperation, and the public needs to be knowledgeable and trust us as we move forward to make these difficult decisions. One of the things that is helpful in our DC area is that we have a DC colloquium of ethicists that meet so that we can all be talking about what the different hospitals in our area are doing so that we are all at the same place if we were to go into a crisis mode, any facility that you would be getting the same standard of care. And that's helpful to the public to know that. Next slide, please. Oh, I'm sorry, these are the scarce resources that we're going to be talking about. Next slide. And that crisis allocation, this is kind of an important point that the public may already think that we're in crisis. And in fact, we've had multiple conversations with the folks in New York and around where we've had a little bit more of a hotspot and asking them, have you actually gone into your crisis management? And it has been discussed that they have come to the brink and they continue to mitigate and they continue to find ways to manage to keep the individual person in their sights. And so it's been helpful in that way. In fact, we may find, and I think it's been reported that ventilators were not necessarily what has come down to be the thing that we've been having to so much crisis about, that we've been able to be saved from that, but that it's other resources. Next slide. So we've been having problems with personnel and having enough doctors and nurses to maintain our standard in that contingency mode still. We've had tents set up, but haven't had to use them. We've had various things in place, and yet we haven't quite got there yet. So some of the things that we're needing to sort of allocate and reallocate, I think is an important point for us to talk about, and maybe that will come up in our Q&A. Next slide, please. I'll just mention that over the weekend, right, the remdesivir has left and has gone across the country in an emergency use setup. And so how that's being delivered, I got up this morning to read news after news after news about how that's happening and how we need to be transparent with the public about that. Lots of people are interested in that, so we can talk about that. Next slide, please. One of the things that I thought about way back in February and March is as the hospitals started to target our COVID population and how to make that work, we were limiting visitors, right? And then we started limiting elective surgeries and we started to shutter down. And now we have a lot of people at home that have unaddressed health needs. And so one of the things that we need to be thinking about is how to get back to treating those folks. We've been doing a lot of telehealth and trying to manage, but we know that folks are at home and they are not being seen, and we need to consider how to get back to that. Next slide, please. Can't go too far without talking about advanced directives. We've been working with advanced directives and planning end-of-life care for over 25 years specifically, and what we know is very low number of people actually make these plans with their physicians or as they enter the hospital, and we need to bring that back to the forefront. We need to be having people involved in these conversations, and I'd be happy to comment about that further. Next slide, please. If the crisis does come, we do need to be ready. Are we increasing our manufacturing? Are we training more people? How can we avoid alarm and anxiety? The use of the triage team absolutely cannot echo that more. There's certainly ways that we can talk about that going forward, so I'll leave that to the Q&A. And next slide. allocation, if we get to that, if we get to the crisis stage, should be based on need, prognosis, and effectiveness. And we do have tools to think about that. My final slide, I believe, is what we should not be doing. And I think those have been articulated pretty well. We can talk a little bit more about the idea of ventilators. I picked up, that might be something I would want to comment again about. But then my last slide just really brings it on that, next slide, Michelle. Thank you. That allocation ethics really is around the public trust. It's around principles. Having to have policies might limit us in some ways. We want to be able to look at the individual patients as well as have very strong grounding in our ethics. So I will turn it back over to Dr. Hyder for some hopefully good Q&A.
Thank you very much, Sarah. Very much appreciate both your experience and your comments. I really appreciated the fact that you framed it also in terms of justice issues and brought on the disparity perspective. And then this tremendously important issue of trust, and particularly, and this is not just true of the United States, and I'm not making a political statement, even though that often slips in my language. But when trust in the government for large parts of the population becomes a dicey thing, then what happens, particularly with respect to guidance, respect to advice, with respect to public health prevention standards. So thank you very much for raising these issues. We've already, I want to move now into the Q&A part. I invite again all our participants to provide their comments and their reflection. I've already noted several. And what I'm going to do is pick and choose from them and direct them to our panelists. Hopefully we'll keep the conversation going. I'm going to also make sure that in the end, they have a minute or two to each provide a closing comment before we bring, and I will be sticking to time. So I don't intend this going beyond 1 p.m. Eastern Standard Time here. So Govind, let me turn to you first. I think this is a very interesting question because you specifically started your talk by saying that you do not want individual providers to be at the decision-making pathway. And therefore, however, I believe my colleague Carlos is indicating that providers also see themselves as being independent decision-making capacity, to be cognizant of that in a clinical perspective. So why not allow them the pathway to take individual clinical decision-making and extend to resource allocation? What are your perspectives if those individual providers were to say, hey, you're taking away part of my decision-making authority?
Sure. So I think this underscores the way in which scarcity is a different scenario from typical clinical care. If in typical clinical care, it makes sense to have providers play a big role in this because, say, if I'm Adnan's doctor, me getting a certain resource for Adnan is not going to limit, say, Sarah's access. But if I'm Adnan's doctor and I'm more senior or I have more power and Michelle is Sarah's doctor, in a scarcity situation, this is going to lead to a lot of problems. Having each individual doctor serve as a kind of zealous fiduciary for their patient with respect to scarce resource allocation decisions is going to lead, we think, to the exact kind of arbitrariness and bias that we're worried about. So that's why I think if there are non-scarce resources, it's important to retain flexibility for the clinician in deciding, when to prescribe, what approach to take. So there are two different questions. Take remdesivir for an example, a therapeutic. The clinician should have the choice of, when their patient gets it, if there are sort of choices about mode of administration, how to talk about that. But in terms of, say, there's not enough remdesivir, if I and Michelle are doctors, it shouldn't be that we sort of argue it out. I think that's where having a triage committee and having clear guidelines where we can point and say, look, essential workers or people in this group that based on evidence elsewhere looks like they get more benefit, they get it first. That helps to forestall this sort of potentially biased and arbitrary decision making.
If I could add to that.
Sure, Sarah, go ahead.
Thank you. Yeah, I think that the triage committee is going to be desirable should we get to crisis mode, for sure, because the clinicians are going to be in the throes of keeping all of these very sick patients ongoing. And so as they have to make these very crucial decisions, it can cause a lot of moral distress. These are decisions they've never had to make in their entire career, how to choose between patients in the moment. And having experts in the science and in ethics who can assist these clinicians, we think will be the best strategy. Now, to your point, can a clinician actually go back and say, but I want to advocate for my patient? Absolutely. I think triage teams are going to have some kind of an appeal process so that the additional conversation can happen. For sure. I think that will be important, but having that separateness will, I think, enhance that unbiased piece of it. So I just wanted to comment on that. Yeah.
Sarah, while I have you, what about standard of care with respect to COVID-19? I mean, that's a key issue outside the pandemic, leave alone. And then the rapidity of the learning process of knowing what the virus is actually doing, responding to it. There's been a lot of concern to bring your disparity context as well in terms of standard of care being applied. There's a question around that. And then that question also talks about other countries around the world, especially low and middle income countries. Would you like to comment on that, especially in view of what you just said?
Well, I think that what we're trying to do is to mitigate the various pieces of the struggle that we're having to provide care so that we can continue to maintain a standard of care the best that we can. And as far as I know, we have been able to continue to do that despite disability, despite various other pieces. There are lots of persons who have difficult complexities that have come down with COVID-19, and they're additive. So the persons that for instance, homelessness has been something that we've seen quite a bit, and how they have very complex comorbidities, but we are continuing to treat them with the same dignity and respect. And when we create that relationship and we have a duty to continue that on a ventilator, then that's where we are. And I think that is an important problem to think about moving forward. But I think that maintaining our capacity various ways will help us to continue that idea of a standard. Mm-hmm.
Thanks, Sarah. Govind, I want to make sure that our participants really understood your point about research participants and access in terms of the ethical argument you're making. Are you specifically talking about research subjects? Are you talking about those who participate in research for solving the COVID problem should get priority access? Could you elaborate a little bit? I want to make sure that in view of a couple of comments that is very clear. Govind, you might be on mute.
Yeah, sorry, I couldn't unmute myself until now. Yes, so this is actually not a part, because it's a co-author paper, this is actually not the part of the proposal that I feel strongest about. But I said this in the chat. I think the proposal is just that if people are participating in sort of approved research on COVID-19, and I think this would look especially important, say, in a human challenge trial, which I think some people have talked about, and I actually, for one, think could be ethical and could make a lot of sense if it led to sort of developing useful clinical information. I think if people are participating in that kind of research, it would make sense to offer them priority for non-research interventions that are the standard of care, and also to offer them, if the research intervention turned out to be successful, post-trial access to that intervention. And I don't think either of those are particularly controversial principles in research ethics. In general, we try to provide people who are in research the standard of care, and we also try to provide them post-trial access to the treatment being researched in the trial if it turns out to be effective. The only complication here is that because the treatment is scarce, it can be a little more difficult to define what exactly constitutes standard of care. But I'm not talking about say, offering priority for unproven interventions to people. I'm saying if there are standard of care interventions that are scarce, like testing, there's some case for offering priority to people who are participating in COVID-19 research for that. And one rationale for that would be as reciprocity for their willingness to contribute to social good. Another would be because it encourages people to participate in trials. So that's the instrumental value rationale. And I can see complexity, I think, especially with the reciprocity rationale. A lot of people are making choices that contribute to the social good. Why should we favor research participants? But I don't think this is some sort of unprecedented or particularly controversial commitment.
Yep, we've seen this before in vaccine research, various things. That's pretty straightforward, I think.
Yeah. So Govind, while I have you, let's go back to this instrumental value, because a couple of comments have made me realize that people are thinking about group living situations. People are thinking about cultures that rely on relationships. So the instrumental value is not about necessarily saving people from the same disease, but also social relationships, dependencies. How will that play out in the ethics of resource allocation from this perspective?
So this reminds me of a response to, it was sadly too brief, to the good question you asked in your letter to New England Journal about dependence. So some states have given some priority. They haven't had to use, most states, Sarah will correct me if I'm wrong, I don't know that any states yet have had to actually activate their crisis standard of care for ventilators. And that's thanks to people doing so far largely what Tony Fauci has said they should do, which is staying home, not flattening the curve to some extent, making it possible, for instance, for a state of Colorado to send nurses and other people to New York to deal with the hotspots there. I feel, and this is not something we talk about in depth in the article, but we say something in the response. I feel like it's important for any sort of criteria of instrumental value or reciprocity to be administrable and to be resistant to bias as far as possible. And that's why I start to get more worried once you start expanding it beyond sort of immediate healthcare workers is, I have an 18-month-old. I would feel awful if I wasn't able to provide care for him. I feel uncertain about whether that should give me priority over other people who are providing other kinds of care in a pandemic. And I worry that that is much harder to assess, especially in a pandemic. Am I actually providing care to my 18-month-old, or am I a dad who isn't doing that? And I think that's why I feel uneasy. I see the attraction of wanting to say more about reciprocity. I think for concrete living situations, the question Gerald asked, that does strike me as a place where we should give priority, but that seems to me more for instrumental value reasons. That's a very just sort of standard epidemiologic principle that you send resources to try to rein in to stop an outbreak. And so that seems to me, at least for, I don't know about ventilators, but for something like testing, PPE, other therapeutics, that would be my rationale for that.
Yeah, I would just add that it's very common to think about healthcare workers and their families and an extension there as an obligation to protect and to treat. So as an extension of that, I think that would add to that.
So Sarah, what about, and in the times where many people think about US first and sometimes US alone, I dare to ask the question that we are not alone in this world, and clearly there's an interconnectivity. So what are your thoughts with respect to lessons we can learn from this from other countries? On the chat board, Spain and Italy has already been mentioned, but also New Zealand, and we actually have some folks from New Zealand listening in as well. So in terms of the ethics around this issue of resource allocations, have you experienced or some reflections around learning from other countries?
Well, I do think we're all in this together. I will say that how our experience with SARS, with Ebola, all the various, we are closer together than we think around the world. And so working together, and actually I did think there was some of that, I think visible this time around in a way where there was better communication globally about what the science was, what was the experience. I remember very early on, we had someone in our ethics consortium had brought in someone from Italy who had been in the trenches there and was still treating patients and telling us what was their experience and how to manage those patients and the ethics that they were going through. So I think that we are seeing a tie together from the science, from the decision making. How we share resources and information is very important, and that can't be echoed enough. The research and the experience that people are having with their patients needs to be shared openly. And that kind of idea of data sharing, I think we've seen some, and I think we'll see more of as we look for around the globe, what is going to be the treatments that are going to be the most successful.
No, thank you. And Sarah, you slipped in an example there that you have a colloquium here at DC. But in fact, what we've seen is the response of leadership at city level for mayors, at state level for the governors, and now at country level. You see different responses from Boris Johnson, from Putin, from Trump, from different leaders. So could you talk a little bit about your point on trust and how that may relate to this discussion on ethics?
Right. So I do think that the leadership at the government level is going to may have, and I certainly am not one to comment on that, but I think that the science leaders need to be connected. And so having a good connection through our CDC, through our connection with the WHO, through the European connection, through our connections around the globe. We need the data that's coming out of China. We need the various pieces of the science in order to move forward. And making that, again, I'll just echo making that information shareable is going to be our best strategy in this.
Great, thank you very much. So going back to you, your interest in looking at some of the metrics around measuring survival and looking at that. Do you want to go ahead and of the questions you mentioned? Go ahead, please.
Sure. Yeah, so let me actually answer first Sonia Suter's in the chat second question, because I think this is an important issue and is complex. If we're just focusing on instrumental value and not on reciprocity, I think then you have to look at whether somebody else could step into the shoes of a worker who was unable to do their job because they were ill or incapacitated. And I think that is something that does differentiate different types of workers who may be putting themselves at the same amount of risk and making the same amount of sacrifice. So I don't think there's necessarily a difference in the amount of risk that is taken by, say, there may be differences but they may not be big, in the amount of risk taken by, say, a respiratory therapist versus a staff member in a hospital who doesn't have medical training, who's cleaning. But when we're looking at instrumental value, you look at, could somebody else do that job if one of them was incapacitated? And I think there's good reason to think the respiratory therapist would be a harder job to have other people step into the shoes of than the job of cleaning. And so I think if you want to focus on essential workers in general, that suggests that your reason for doing that, I would think, would really be more reciprocity than instrumental value. Instrumental value is not just about, are you contributing, but it's about, if you couldn't, would somebody else be able to do it? Reciprocity brings in the question of, are you contributing? And so I think really the second question would be more about reciprocity. Sonia and I think an earlier commentator also asked about probability of survival. And I think it's also maybe an area where Sarah and I differ at least a little bit. I read Sarah saying you should ignore whether somebody is going to die after hospital discharge very soon. And my understanding is I think that's the Georgetown policy. I don't think this is the correct policy normatively. I would do it more the way that lung allocation does it, or the Pittsburgh policy does it, where you look at something like 1 or 5 year survival. And I can see how doing it that way would disadvantage people with conditions like metastatic pancreatic cancer that are likely to die soon, even if they are able to survive COVID-19 treatment. But I think, again, when we look at lung allocation and other sorts of interventions, this would have large benefits for a variety of other people, including people with other disabilities that don't affect, and that's most disabilities, I think, 1 or 5 year survival. And so I think the gain in saving lives for a reasonable life expectancy, to me, and again, because this is used in lung allocation especially, I think outweighs a concern we might have about people not getting an equal chance. I think even if you just focus on survival to discharge, people are not going to get an equal chance. Some people that have other conditions may have a lower probability of survival to discharge. When you look at, say, the Maryland, Texas studies, and at the other guidelines, I think there's broad agreement that, and not just a utilitarian value, but saving more lives matters. When we do public health interventions, things like delaying surgeries, as Sarah points out, that has really big burdens for certain specific groups, even if it saves more lives overall. And I think we should acknowledge that, but it seems very hard to me to get away from saving more lives and caring at least about shorter term life expectancy.
I would just want to echo that certainly comorbidities and certain types of, like you suggest, maybe a cancer diagnosis and the treatment thereof does add to, the bigger picture of the patient's suspected ability to survive the COVID. There's no doubt on that. It's just that we can't arbitrarily say that this particular type, like people with cancer can't get treatment. Well, we would never say that. It can have an additive effect to the success of the treatment. You would never sort of as a group give a blanket and say this type of diagnosis would not be treated. So I think
totally, I agree with that. We have a paper with Doug White in a job that will come out talking about not using categorical criteria.
Right.
Yeah. But you both understand that there's a lot of concern in the community, right? We've all heard of senior citizens arguing that they feel that they are being discriminated against. We feel people with comorbidity very worried that if they were to enter a hospital, they would somehow fall down the totem pole for allocation of clinical resources. And of course, then the notations from minority populations of great concern, both in terms of either racial ethnic minorities or in terms of socioeconomic status. So I think the discussion versus the perception of what's going on in terms of resource allocations, there can be a disconnect. What can we do to help that disconnect?
Well, it seems like maybe we need more transparency in what's happening in the hospitals. But right now, people are coming in and they're getting the care they need, regardless of their background and any disproportionate idea that that everyone is getting the same care, depending on their clinical condition. And I think that's the most important thing that we can say, is that clinicians have been able to use their expertise. The science has been changing. I can remember 90 days ago, we did not know as much about this virus, and we have really been able to see some success. In fact, when I was in the hospital recently, it was helpful to see that there were patients, that were going home, that fewer patients were dying. And it's really important for the public to know that we're getting better at this.
Yeah, I think to that question, I think that the problem about differences in people's pre-existing comorbidities or life expectancy or something like that is a really challenging problem. I think that's why it's important not to try to use predictions of very long-term life expectancy. I do think, so underscoring Sarah's point that right now we're not in that crisis standard of care position with respect to something like ventilators. And then beyond that, I think thinking seriously about ways that the health system overall can try to ameliorate these problems of bias, of structural racism, of other health disparities. And I think a hard question is whether you try to do that solely or primarily at the level of your triage policy, or whether you try to do it in upstream ways. I think if you build it into the triage policy, absolutely the wrong way to go is this idea that we have to use a lottery. If you look again at the Maryland, the Texas results, diverse groups of participants just reject that. They think that is not an appropriate method, and I agree with them. I think if we look at our overall response, saving more lives has to matter. I think I've been working with a group of folks in Massachusetts who I think they just gave a presentation at Johns Hopkins on Thursday of last week, Typhon Sonmez and some colleagues, thinking about how to use what they call a reserve system, where you assign, say, some ventilators in ways that track geography. So even if all the hospitals are in higher income areas, you initially reserve some ventilators for if somebody comes in from an area that is more socioeconomically disadvantaged, that's a priority. I think that is the way, if you're trying to address disparities in the triage process, to do that. But I think in a lot of ways, the important thing is to also be trying to do more upstream to ensure that there's adequate distribution of testing, other things. I think some of these issues are really hard to address in ventilator triage, although I do think the system that Sanmez and others suggest is really promising.
I do think also, just to add, that planning for this kind of a pandemic we have some history here. And so in the various, over the last 15 years, the types of things that have happened, that we even found out that we had, N95 masks in the basement of some hospitals that have been there with the ties eroded because they'd been saved for this next emergency, and yet we weren't there yet. And so the planning is super important. One of the things that was, I guess I'm not surprised, right? But they're now opening up the opportunity, I think, for a public health service to actually put together resources in more of a crisis team that might deploy, right, to various top parts of the country to help build them up and to support them as they mitigate, again, other areas of their health system to be able to adapt, right, to what we're doing. I think planning, safeguarding, and guidance are really important from a top-down perspective.
So maybe since you're there, Sarah, I'll ask you to make your final closing comment. I want to make sure that you have anything to comment on, anything that hasn't been touched, because I'm going to wind down.
Sure.
About 3 or 4 minutes left only in the webinar. Particularly, I was also going to ask the question that was earlier on in the chat about the duty to plan and the nature of the public health duty to plan in advance and to learn from this for the future. So Sarah, first to you.
Yeah, I would say that we're already doing that. We are taking that obligation to plan, and organizations are continuing to plan forward. We're planning for the next 4 months, the next 6 months. What do we do in 18 months? How do we maintain this level of surveillance and capacity to move forward? I think as long as we can maintain the public trust, be as transparent as possible, get the feel of the region, who are the people that we're treating, and how can we best use that information to align our decision making. The longer that we can keep making decisions for individual patients, the better we are. As long as we can stay out of the crisis standards, that's going to be our best. So we have done a lot of creativity in making ways for patients to be cared for, to be tested. We have to increase testing. We need to keep people safe and to suppress the virus. So I really appreciate the opportunity to be part of this conversation.
Thank you. Over to you, Govind, for final closing comments.
Yes, I totally agree with. The most important thing, really, honestly, is if we can get test, trace, and supported isolation. That's much more important than anything I'm doing about triage, because that keeps us from getting there. At the same time, I would say, when you see people raising concerns or fears about triage policies, I think it's important to ask the question, say somebody is upset about some proposed policy, what would be a better way of doing it? And the tragedy is that if you have a situation where there aren't enough resources for everybody, there's going to be somebody who's going to have an outcome that's really tragic and that's really ethically troubling. And that's true of any system. That's true of first come, first serve. That's true of the lottery. And I think that's what underscores the importance of the point that Sarah made, that we need to focus upstream on keeping us out of that crisis situation. But if we get into that situation, I do think that there are policies, the Pittsburgh policy, for instance, that I've referenced in the chat, that I think do a job, not one that sort of everybody must agree with, but I think do a very reasonable job of trying to identify the idea of saving more lives, avoiding categorical exclusions, avoiding some of these biases, and trying to get at, as best we can, a fair way of dealing with the a tragic circumstance if we do end up in crisis standards of care.
Well, I mean, I must say, ladies and gentlemen, this has been a remarkable, I mean, it is impossible in 60 minutes to cover everything to discuss on the ethics of resource allocation with respect to COVID-19. But I hope you will agree that Govind and Sarah have really taken us through, at least thinking through some of the critical issues, whether it's with respect to thinking about the criteria, thinking about some of the ethical principles or their applications. We've talked about notions of instrumental value, reciprocity, justice, how disparities face into this, issues of trust, issues of measurement and metrics, and what can guide. But also, I think a very, very fine point, which is that we are still evolving. And to me, that's a very important statement that I hear coming from both our speakers and to many of your comments. That is, every day we are learning more. As some of you indicated, literally just an hour or two ago, in the Senate hearings, some of the leading experts are raising trying to respond to questions, but also raising other questions, which means that we haven't closed the book on this. Please join me in thanking both Sarah Vitone and Govind Prasad for joining us today. I'm grateful for this opportunity to moderate this. This was really good. Please remember that this is a webinar series. Our next webinar is on May 26th. And on the 26th of May, we'll be talking about maternal child health and ethics in COVID. And we have some great speakers like Dr. Lena Wen and Dr. Amita Vyas coming in talking to us. I look forward to seeing many of you there. Thank you again, Sarah and Govind, and thanks to our team at Milken Institute School of Public Health for your participation. Take care, everyone. Stay safe, and keep the ethics flag rising high. Bye now.
Thank you all very much.
Thank you.
Are you able to close out other people?
Hey, Slide already went out. What do you want, Kizzy?